Those of you who don't know Kinesh, he's a consultant gastroenterologist at Chelsea and Westminster in London, and he's going to start the ball rolling with an introduction to this concept. And over to you, Kinesh.
Great. Thank you very much, Anthony, and thank you for asking me to present tonight. I am going to talk a little bit about this whole treatment area, and I think the first thing to say is that this is a challenging area and that always causes a bit of consternation and angst in the people seeing these patients. I'm going to talk a bit about the treatment options at the moment, and I'm going to hand over to Anthony, who's going to give us the bombastic bit about the novel diagnostics and treatment approaches, and what we should be doing or what we should think about, should be considering doing in the future. And then Marcus is going to end with the $64,000 question that we're always asked: is surgery the right way to go for these patients? And that should hopefully give us a bit of light about that, because it's something that comes up again and again and again. Okay, so as I said, this is often how people feel. It's how GPs feel, it's how I often feel, and I'm sure it's how ENT surgeons feel as well when faced with these patients who have troublesome symptoms. And hopefully during this talk we'll get a little feel of why that is and why we all, patients and the physicians, will feel frustrated in this arena. So what are throat symptoms? So these are the common things that people present with. It's pain, globus, pain when they're swallowing, recurrent coughing, throat clearing, difficulty swallowing, or changes in the voice. And they're all slightly different, but patients always localize them to the throat. And they sometimes ascribe their symptoms to reflux. Are they right? Are they wrong? Who knows? But people complain about these things. They're often very debilitating for the patients. They cause a huge amount of anxiety, and people suffer them day on, day in, day out, and they don't know what to do. And they seek medical attention, and that's probably one of the reasons they become quite so frustrated. So in general practice surveys, if the GP asks people about throat symptoms, a quarter will say they've got throat symptoms. So these things are incredibly common. I don't think there are many conditions where you get 25% uptake in the general population of people attending general practitioners for their athlete's foot or anything else. And 6% of middle-aged women have globus. So these are big numbers when you translate these to a population level. And these throat symptoms have been made analogous into LPR. And I'm not an ENT surgeon, but it's something that I work closely with ENT surgeons all the time. And this is one of the dilemmas, because throat symptoms don't necessarily equate to LPR. And this is one of the reasons that patients get frustrated, because they're not actually sure what's going on. So LPR is when you get reflux from the stomach up into the larynx. And why is that? Why does that cause a problem? Well, reflux itself is when gastric contents move at an abnormally high level into the esophagus. And we know that people with LPR have higher levels of reflux, about 40% of them, on a background of 20% in the general population. So reflux is more common. But what we do in the esophagus, or what the esophagus does, is it's a stratified epithelium. It's much more able to deal with this acidity coming up. The larynx is not the esophagus. Of course, that's true, but the epithelium is completely different. It's the columnar epithelium. It's much more sensitive. And there are some studies showing one bout of reflux or gastric contents or bile or pepsin or anything moving up in there can cause damage to the larynx. So we know that that part of our body is exquisitely sensitive. And is it that is the problem here? And is it that that recurrent damage is what's causing the problem, and the throat symptoms and the persistent clearing and everything else that's causing so much anxiety and difficulty? And we know things like bile, if it's there, cause high pH refluxate, and it's got enzymes and agents that really tackle that very exquisitely sensitive laryngeal epithelium. And you can imagine the larynx is highly innervated, and if there's anything wrong there at all, we would expect that we would feel it all the time, and that's what these people complain of. So what could it be? So this is a differential diagnosis. Is it postnasal drip? Is it something in the nose? Is it that they've got a behavioral problem, throat clearing? Are they smoking? Are they talking too much? Do they have verbal diarrhea? Is it an environmental problem? Is it stress? We have to be upfront about that stress certainly can manifest itself, just as it can do in the joints or the muscles or the stomach, or with diarrhea. It can also manifest itself in the throat. And that is one of the differentials, and one that's particularly difficult to address. Or is there something going on, and is the larynx being sensitized, and that's causing the problem? And once we consider all of these things, everyone feels like this all over again. We feel like this, and the patient thinks, like, what do we actually do? And therein lies the challenge. So on a practical level, the patients that we see in secondary care are not the ones out there with the majority of the problem, just like everything else. And we have often this ivory tower view of things, whereas most of this is managed by general practitioners. So most patients are diagnosed there by their GP based on their symptoms alone. And those symptoms are different. If they have dysphagia, of course, they need to come and see a gastroenterologist and have an endoscopy and all those sorts of things. But if they've got pure throat symptoms without anything that makes you think, well, this might be cancer, then the GP will often initiate some sort of treatment themselves. If they see an ENT surgeon, they will do a flexible laryngoscopy, nasendoscopy, and if they see us, well, we will scope them, but we all love scoping. But if I'm completely honest, I'm not sure that has a huge yield, and whether it actually moves the patient further forward in terms of their diagnosis and improving their symptoms is unclear and unproven. We may do a pH catheter study to look for reflux. Is there reflux coming up? Is that a useful test? Or if the patient can't tolerate it, or they don't want it, and lots of people feel like they don't want a pH catheter study because of the fear of discomfort, then a wireless pH study, is that helpful? Again, that's a good test for reflux, but is reflux the driver of these symptoms, or is something else going on? And so pragmatically, what has been done for many, many years is give them some PPI. Could it be reflux? Reflux is a bit more common in people with throat symptoms, so let's give them some PPIs and let's see how they get along with that, and let's push the problem down the road. So, as I said to you before, gastroesophageal reflux and LPR, they often coexist. They're 40% of them, and we can get 50 reflux events in the esophagus, and that's normal. But people are showing 1, 2, 3, 4 reflux events up in the into the larynx can be pathological and cause inflammation and symptoms. And there's this debate about whether acid is needed, but we know that you don't necessarily need acid if you have bile coming up into the throat. And we all we know from if you see someone with a biliary stoma, bile is one of the most caustic substances that we have. It's up there with feces. You get feces on your skin, it'll burn. If you get bile on your skin, it'll burn. You can imagine that if you're getting bile in places where it shouldn't be, like the throat, then it is going to burn there too. There's no reason why it would be any different, particularly in an area of the body that is so exquisitely sensitive. So why is this done? So there have been lots of studies along the way, and this is an old one from 2007, and they took 49 patients and with throat symptoms, and they did a pH catheter study on all of them, and they found that 27 of those had abnormal levels of reflux in the upper esophagus. So they gave them some esomeprazole, and they did it again, and it worked in 22 out of 27, which is a good marker of how good esomeprazole is at decreasing acidity. But out of the other 5 that didn't have decreased acidity, 4 of them felt better. There's something else is going on here. It's clearly not just an acid problem. And given it's not an acid problem, people have thought, done small studies, uncontrolled studies along the way, saying, oh, well, PPIs seem to work. I've taken my 12 patients and 8 of them felt better, so PPIs are a good thing. And so this group published this large multi-center study, a pragmatic real-world study, which I think is, the way to go. And increasingly, certainly journals like the BMJ want to see real-world data rather than ones from tertiary centres. And they looked at PPIs to see, could they help treat persistent throat symptoms? And it was 8 centres, 350 patients, and they had unexplained throat symptoms. So hoarseness, throat pain, globus, clearing, cough, or choking. And these are all common symptoms, and they were evaluated, and they had a reflux symptom index, which I'll talk about on the next slide, and they had flexible nasal endoscopy as well. And this is the reflux symptom index, and people rate it themselves 0 to 5, depending on how bad their problem is with those issues: hoarseness, clearing your throat, swallowing, coughing, breathing, and all the things that people find difficult when they're dealing with this. And you can see that there's 9 items, 5 each, so that comes out of 45. And what they did was they analysed this one of 2 ways, because you could get, you can get 5 marks just for having simple chest pain without any throat symptoms. So they took 2 markers. One was just this out of 45, and one of them they just eliminated the bottom one. So that was just what they called the RSI HB, which will be important later. And the HB indicates nothing to do with heartburn in it. And they looked at those outcome measures saying, did PPIs help? And if they were on a PPI, they had a 4-week washout, and then they were given a high dose of lansoprazole, 30 milligrams twice daily for 16 weeks with a matching placebo. Because in this setting, there's been no studies looking at one PPI being better than another. And 27% of people receive PPIs in the last 12 months, and that's relevant because, again, it's a practical real-world study, and we know that PPIs are commonly used in general practice to deal with a multitude of symptoms. And at the end, this is always interesting and something often not mentioned in papers, but really gives you a good clue about how good the drug is. So only 42% of people on PPI guessed that they're on PPI, and 56% guessed in the placebo group. So no one really knew what they were taking, and there's not, and that gives you some idea about what the results are going to show. So these are the scores, and they've looked at the reflux symptom index. As I mentioned, they've looked at when they've taken away the heartburn score, they've looked at other reflux scores and a quality of life score. And essentially with all these scores, what you need to essentially be aware that the higher the number, the worse the symptoms are. And you can see, if we look at the top red box, that actually at 16 weeks, both groups have improved significantly from 22 to 17.4 and 15.6. And then at 12 months, both groups have improved again. And that goes for every single one of these measures. So essentially, everyone got better on PPI or placebo treatment. And their very practical conclusion was that lansoprazole really didn't help over placebo for patients with persistent throat symptoms in a true randomized controlled trial. And the downside of this was there was no reflux testing. So, we don't know if having reflux changes whether lansoprazole or PPI would be helpful. But in a pragmatic GP type way, actually giving people PPIs for throat symptoms is probably unhelpful. And that led the NIHR to issue this alert saying, don't give out PPIs willy-nilly to GPs. And so, what next? Because that's really to put the kibosh on what people have done. It's easy to write a prescription, it's easy to send the patient away saying, try this for at least 3 months, maybe 6 months, and come back and see me again. And what next is what I call the ascetic plan. And that is very different to the ascitic plan, which means drinking plenty until you've got ascites. No, this is the ascetic plan, living like a monk. Okay, and if we have a look at LPR diet on Google, you can see there's 106,000 results for that. So people are interested in this, and people are interested in diet and lifestyle changes. So stop smoking, less caffeine, no peppermint, even no decaffeinated tea or coffee, no acidic or spicy foods, dropping the pH in the larynx if pepsin can be activated, smaller meals, don't exercise for 2 hours after eating, don't eat or drink for 3 hours before sleeping, lose some weight. And all this is good lifestyle advice, but the quality of evidence for all of this is very, very poor. It's observational. No one's looked at this in a methodical, systematic way, but we do it because we think it might make a difference. But we're pretty sure it probably doesn't make very much difference, and people essentially don't want to follow this, so they say that they're better. So we're back to this differential diagnosis. Which one of these is it? Is it something else? Should we be doing something else? And what do I do in my practice? I often think about things backwards. And I think at this stage, often we think, what are the reasonable medical options? What treatments do we have available that could be useful? And because that's all we have, we either do nothing, or we give them some medicine, or we do some sort of procedure. And to my mind, the treatment options here it's either baclofen, which reduces transient lower esophageal sphincter relaxation, but it's complicated by sedation. Neuromodulators, for which there's a little bit of low quality evidence, tricyclics, gabapentin or pregabalin, all of these have been published. I often use nortriptyline for a minimum of 3 months because that addresses many of the differentials of hypersensitivity and assess, does that make a difference? And that can help people, and making sure you've got the right dose and titrating it upwards is probably helpful too. But I think that for me is often my next step, but it is a grey area, and there certainly is no high quality data behind that assertion. And then they come back. So what next? Do we do speech therapy? Do we do some more testing? Do we send them off to psychologists for CBT, or that's all done online now? Or do we have an operation? And the answer to that is we don't know, and that's why I'm going to hand over to Anthony now to hopefully shed some light on some of these conundrums.
Thanks very much, Kinesh. So we don't have any open questions. If anybody wants to ask a question directly, they could turn on their video, raise their hand, and we can do that. Otherwise, I will ask a couple of questions myself, and then we'll move on. So Kinesh, in terms of using neuromodulators, one of the things for using neuromodulators in IBS is that about 30% or more of patients can't tolerate the side effect profile. Do you find the same in these LPR patients?
Yeah, absolutely. And that's why, amitriptyline used to be the rage, but actually I find the majority of people couldn't tolerate amitriptyline due to sedation. Nortriptyline is better tolerated. There's certainly less sedation with it, but even then people have issues with palpitations and sometimes sedation as well, and feeling of depersonalization. But I'd say the majority of people can tolerate it. But again, with all these things, there is a placebo effect, and no one's looked at this in a systematic, rigorous, and controlled way. So, but we aren't left with many medical options. And what do we do when we're not left with medical options? We use things with low quality evidence, and that's what we're doing.
So we've got a question here from an attendee asking any role for Gaviscon Advanced.
So yeah, I think Gaviscon is probably the thing with the best, well, I'm not going to say evidence-based, but the best hypothetical evidence in that, we know that PPI, what have people done in the past is use PPIs and then add in ranitidine or cimetidine or something else like that, which we know now is pretty hopeless, both partly because H2 blockers are affected by tachyphylaxis. So, the effect wanes after 3 or 4 weeks. Anyway, and there's again another placebo effect there. With Gaviscon, there is a barrier function that's forming that raft and actually coating the larynx if there is damage caused by reflux from the stomach, and if that is the diagnosis, is likely more helpful than any of the other strategies. And also, there are no side effects with Gaviscon, so it is probably the best bet here.
I've got another question, but just before I move on to that, there is a product called Zivorel that we were looking at that is, I think it's marketed by Norgine, and it's hyaluronic acid in sachets, which seems to have some use in European studies, but not much in the UK. We did ask if they were interested in doing a study, and they weren't, strangely. But that's another thing that we tried empirically with patients as a kind of coating for both the larynx and pharynx and proximal esophagus. So the only problem with it is it has quite a lot of artificial sugar in it, so it has a quite high xylitol content, and from my talk later, that might have its own problems. So this question is from Mahmoud Wahed. He said, who should investigate and manage LPR, ENTs or gastros?
So I think a little bit depends on who they present to. I think with the NHS, the way it is, sending someone to another specialty, at least when we know that the initial management of this is fairly straightforward, so it should be the person that sees the patient. It can be the GP, it can be ENT, it can be gastroenterology. I think if they're coming up from the GPs, then they should probably go directly to ENT, but they're in front of us, then I think as gastroenterologists, then I think we take the lead, and only if symptoms are refractory, they go off to ENT.
Great. So this is a comment from Craig Vickery. Are you happy to give this group a diagnosis for LPR at this point? I think what he means by that is, do we say they're LPR-like symptoms, or, I mean, we'll probably interject during this study, because we specifically talked about throat symptoms rather than LPR with the title of this, but at what point would you consider giving someone a diagnosis of LPR?
I think LPRs, they have to have someone look down and say there's evidence of damage here. And there's a scoring system for ENT surgeons that they'll be able to talk about more than me. But, I think if on a pragmatic level, not everyone who has all these symptoms can see an ENT surgeon. There isn't that capacity in the NHS. So there has to be a more pragmatic way of trying to deal with this and filter out the ones that need to see an ENT surgeon.
So another question from me, when PPIs first came on the scene, 30 years ago, we were doing some of the early studies, and the concern for us all at that point was that these were going to become lifestyle drugs, and people wouldn't lose weight and do all these different things. They would just take their PPIs and carry on as normal. And of course, it's been very convenient because they're so effective in drugs. Do you think it's going to be hard for people to break the habit if they see a patient with throat symptoms to still go down this road, even though the guidance is fairly clear?
Sorry, I'm not sure. I didn't catch that. Sorry.
So I'm just saying, do you think it's going to be hard for people to break the habit after so many years of prescribing?
Yes.
PPIs?
Yeah. I mean, I think that is that. There's no doubt about that. And also, it's an easy option, isn't it? To give a prescription for a drug. So take this medicine. We hope you'll feel better. I'll see you in 6 months. That is much easier than dealing with all the other issues.
And I think this is mirrored by Rami Spice's comment here, saying, despite this study suggesting there's no difference in response, there's still people who do respond to PPI, and should we not give those an opportunity to respond if they're going to?
Well, so I think that's what I said, actually. So, everyone responds. So instead of giving them PPI, you should give them a placebo, because we know that they respond at the same level. That's what the study shows. And all the previous studies have been low quality, probably hampered by selection bias and everything else. So yes, they do respond to a PPI, but they also respond to placebo. So we have to have a mechanism of dealing with that doesn't involve dishing out active drugs to people who will respond if we don't give them an active drug.
Okay, just checking if there's any more questions. Okay, so I think we're okay. So I'm going to hand over control of monitoring the questions and comments to Kinesh. And I think there's one more question that's just come in. Is there any role, this is from Den Cartledge, any role for prokinetics?
No role for prokinetics at all. I mean, the issue with prokinetics as well is that most of them have significant issues with toxicity if used long-term. Domperidone, azithromycin, metoclopramide, which is a black box warning in the US. So, we try to minimize use of these anyway. And if you've got a long-term problem, these don't work anyway, but even with people who do benefit from prokinetic, we try to minimize their use. So no on every level to that.
And one final one for me, in terms of the physiology, which is obviously closest to my heart, most of those studies didn't use physiology to correlate with response to drug. Is that the biggest weak point of most of these studies, that you're not actually identifying those people who got reflux before you try and treat them for it?
So I think that's right. Although the first study they did identify people with reflux, and they showed that those, who didn't have a response to reflux treatment still got better. So there's something else here.
Okay. So I'm going to close that down. And then I'm going to share my screen.